Hi friends, I'm Dr. Arshad Nadeem Awan. Hope you are enjoying well, hope you are enjoying life, and hope you are enjoying practicing ultrasound. Today my topic of discussion is liver. Liver is the largest gland of the body and it's ideal for the evolution on the ultrasound machine. As liver hosts many pathological processes, so it is easy for the ultrasound to pick all these pathological processes. For the fatty liver, ultrasound is ideal to pick up the fatty changes, fatty infiltration. For the surveillance of the different liver masses, ultrasound can be utilized. For the intervention of the different processes, ultrasound machine is utilized especially to take the biopsies, especially for inserting any of intrahepatic devices and ablation of the malignant tumors. Ultrasound is also utilized. During the surgery, ultrasound can be used as an intra-operative procedure. So keeping all these in view, the importance of the ultrasound of the liver in view, I have divided the ultrasound videos into 7 parts. In the part first, I will explain the normal anatomy of the liver, how it will appear on the ultrasound images, how we will appreciate that. In the part first, I will discuss about the congenital anomalies, how the cysts appear on the liver, how many types of the cysts are there, how we will diagnose, how we will conclude. In the part second, I will particularly mention about the infectious diseases, especially the viral infections, including all A, B, C, D, E, how it will appear on the ultrasound, how we will advise further investigation on the basis of the ultrasonographic imaging. In the infection disease, a separate video would be made for the bacterial infections. There are multiple liver abscesses and some other amoebic infections. So I will include all these in the separate video. The vascular pathologies would be discussed in the separate videos, including Budd-Chiari syndromes and the liver masses. Especially there will be a special video for the liver masses, including malignant masses, including benign masses, how we will differentiate. All these would be included in that video. At the end, I will include the trauma, how the traumatic liver would be appear on the imaging. So this would be included as in the last video as well. So keep watching my video. So let's start from the ultrasound imaging. The ultrasound imaging, liver has 3 lobes, right, left and quadrate lobe. Liver has a very smooth margins. It has dual blood supply by portal vein and hepatic vein. Portal vein appears ecogenic. You can appreciate well ecogenic layer of these veins. So these are all portal vein, while hepatic vein appear to be hypoequic and there is no ecogenic line. So far its size is concerned, 15.5 considered to be a normal size. Any increasement more than 15.5 centimeter would be considered as hepatomegaly. These are all the portal vein. You can appreciate ecogenic layer on the portal vein. Ecogenicity is normally homogeneous and it has a smooth border, smooth outline. As compared to the right kidney, it appears hyperequic, while as compared to the spleen, it appears slightly hypoequic, and liver has smooth margin. There is no irregularity on the ultrasound. Yes, so this was all about the normal structure of the liver, which we can appreciate on the ultrasound images. Its border, its internal structures, its ecogenicity, eco pattern. So all we have discussed at length in this video. So now I'm jumping towards the congenital abnormalities of the liver, which include different sorts of benign cyst. Sometimes it appears as a peribiliary cyst. Autosomal dominant polycystic disease is a specific disease in which there are multiple cysts appears within the liver parenchyma, and beside this I will also discuss about the liver hamartoma. These are all the congenital anomalies, and most often you will come across all these findings on the ultrasonography. So let's start looking for the congenital anomalies on the liver on the ultrasound images. In this image, you can appreciate a well-defined, round, and a isoequic cystic lesion. This is a classical example of the simple cyst, and this is likely to be a developmental anomaly, or this is like to be a congenital problem. So the cyst appear in this fashion. Cyst maybe in the right lobe or left lobe. Here in this image it is in the left lobe, and now this is the right lobe cyst. You can see and appreciate a size is a little bigger than the previous one. So it will also, sometime if it is small, it will cast aquastic shadowing, while in the large cyst there might not be any aquastic shadowing. You have to just measure the size. You have to mention if there is any internal content or not. If no, so mention that there is a clear wall, simple thin wall cyst. This is another small cyst. Here you can appreciate aquastic shadowing as well. So sometime if the cyst is small, it may cast aquastic shadowing. So these were all three examples of the simple hepatic cyst, and these are all the congenital cysts you can write on your report. So the report will be in this way. Ultrasound report should contain all these information. It should be in this way: that a well-defined thin wall simple anechoic cyst, measuring, give the measurement in the right lobe or left lobe, and put the Doppler signal on if there is any flow or not. So mention that no vascularity noted on CDI. CDI mean color Doppler index. In the conclusion, mention that right hepatic lobe simple avascular cyst, likely congenital. So it contains all the information: size, its structure and its location, and you have also concluded with a proper diagnosis that it may be a likely congenital cyst. So in these images you have seen simple cysts. Simple cysts are quite common on the ultrasound, and especially in the liver. It appears in the right lobe. It involves right lobe or left lobe. It may appear single or multiple. Usually it is single wall, thin wall, anechoic, and usually these are all asymptomatic. There is no symptom. If it is symptomatic, like in case of any hemorrhage or infection within the liver, so it will give rise to symptoms, especially pain or especially fever. So in those conditions the intervention is required. For the intervention purpose, ultrasonically you can take the fluid out from the cyst for the examination purpose, for the cytology purpose and other investigation as well. And in certain cases we need ablation by inserting the alcohol within the cyst, just to destroy its layer. And in the third entity, if there is intramural nodule or thick septation, so then the CT scan should be advised. So this was all about the cysts. On this image you can appreciate a well-defined round cystic lesion with low-level internal echoes. So when there is low-level internal echoes, so this would not be a simple cyst. You will have to call it as a complex cyst. Measure the size. Mention it has a smooth boundary and it contains low level internal echoes. So this is a complex cyst example. So complex cyst may appear as a thick wall cyst having a thick septations, intramural nodules, and all these would be appear the way you are seeing this image. And this is a classical example of this complex cyst. So you have mentioned the size, you have mentioned the intramural nodules and thick wall with thick septations. The ultrasound report should contain all these information, like a well-defined complex cyst, measuring, give the measurement in the right or left lobe, having low level echoes, debris, thick wall and septations, and also look for the vascularity. If not, so no vascularity noted on CDI. In the conclusion, mention the complex cyst with low level echoes, debris, thick wall and septation with possible differential of hemorrhagic cyst or cystadenoma. So as I mentioned that there is two possibility, it would be hemorrhagic cyst or it would be cystadenoma. Mention on the report that clinico-lab correlation is suggested. In case of any doubt, further radiological imaging may be considered, so that in this way this would be a clear quite conclusive report. Complex cyst of the liver is defined as irregular wall, intramural thickening, or intramural nodule, echogenic foci or debris. This is classical example of the intrahepatic complex cyst. Intrahepatic complex cyst differential include biliary cystadenoma or metastatic cystic metastasis. So if you did find these complex cysts, you should advise contrast enhanced CT scan for the further evaluation. Look for this image. You can appreciate small tubular clustered cysts at the area of porta hepatis paralleling the bile duct and portal vein. It usually appears small, sometimes it appears in large, and they may reach up to 2.5 centimeter in size. Most often, it appears at the junction of the porta hepatis or along the bile duct, or sometime at the area of the right and left hepatic ducts. Look at this is another example. Here you can appreciate a tubular structure cystic lesion. Actually, these are all perihepatic cysts, so therefore it should not be confused. You have to mention the structure of the cyst, you have to write down in which location you have seen all that, and beside this you have to put the color Doppler on whether it contain blood flow or not. So these are the classical example of peribiliary cysts. Mention on the report that multiple tubular cystic structures are seen at porta hepatis, largest measuring whatever the measurements is, mention it without any vascularity on CDI. In the conclusion, mention that multiple tubular cystic lesions at porta hepatis, most likely peribiliary cysts. As I mentioned that these are congenital cysts, so you can just write on the report that clinical lab correlation is suggested, and these reports should contain all these information which I have mentioned here. Peribiliary cysts are seen especially in severe liver diseases, and these cysts ranging from 2 to 2.5 centimeter in size, and especially seen at the porta hepatis region alongside the right and left bile duct, hepatic duct, and biliary tract. So on the ultrasound you will appreciate discrete masses, a cluster of the cyst at the area or at the junction of the porta hepatis. So this would be likely peribiliary cysts. This is the classical example of autosomal dominant polycystic kidney disease. You can appreciate multiple well-defined cystic lesions within the liver parenchyma, and you cannot easily appreciate the liver parenchyma. The kidney size would be enlarged. As I mentioned that in 75% cases of autosomal dominant polycystic kidney disease, you will appreciate cyst on the liver as well. So whenever you come across with the polycystic kidneys, you must scan liver for the presence of the cyst, as in 75% there would be liver cyst as well. This is another example of the polycystic kidney. You can appreciate that the liver is that the kidney is quite enlarged. You cannot easily appreciate its size, and multiple cysts are there interrupting the liver parenchyma. So again, this is autosomal dominant polycystic kidney disease, and in this case you have to scan the liver as well for the presence of the any cystic lesions on the liver, and mention it on the report. Mention on the report that both kidneys are enlarged and its parenchyma is interrupted by multiple cysts of variable sizes. You have already scanned the liver and you have seen the cyst on the liver, so liver parenchyma also contain multiple cysts or single cysts or whatever you have seen. Mention the size of the cyst on the report as well. In the conclusion, write down that features are consistent with autosomal polycystic disease involving both kidneys and liver, because you have seen cysts within the liver parenchyma and also seen cysts within the kidney. So this would be the classical example of autosomal dominant polycystic disease. On these images, you can appreciate bright echogenic foci in the liver parenchyma with distal comet tail artifacts without any obvious mass effects. So this is a classical example of biliary hematoma. These biliary hematoma are small focal developmental lesions and benign liver malformations. This is actually congenital malformation, and their size usually happens to be less than 1 centimeter. Multiplicity of these lesions, sometimes it causes confusion with the metastasis diseases. So therefore you have to mention on your report that further imaging is required, so to differentiate whether these are metastatic condition or these are the real biliary hematoma. So we'll have to put all these things on the report. On the report mentioned that liver parenchyma shows multiple echogenic less than 1 centimeter foci with comet tail artifacts, and in the conclusion mentioned that multiple echogenic foci in liver with comet tail artifacts suggestive of biliary hematoma, and must mention that contrast enhanced CT CECT stand for contrast enhanced CT suggested for differential of metastatic diseases, because on contrast enhanced CT these liver hematoma will appear hypodense. And it's also worth mentioning here that sometimes calcification of the liver also may also confuse with biliary hematoma. The difference between the liver calcification and biliary hematoma is that the calcification of the liver will not be having that dirty shadowing and will not be having a comet tail artifact, while in biliary hematoma you will see there will be a comet tail artifacts which will be easily distinguishable from the hepatic calcification and biliary hematoma. Biliary hematoma is a congenital abnormality. Usually, multiple cysts can be seen less than 1 centimeter, and this is actually anomaly of the bile duct. On the ultrasound, the characteristic features are a small echogenic foci less than 1 centimeter with comet tail artifact, can be easily seen within the liver parenchyma, and these are happens to be multiple in or sometimes you will find numerous small echogenic foci with comet tail artifacts. So this would be congenital hematoma. Yes, friend, this was all about the liver cysts, congenital liver cysts. We discussed about the simple cyst, we discussed about the biliary cyst, we discussed about the autosomal dominant polycystic disease and also biliary hematoma. So hope this will be a very helpful video for you. Keep watching my video. Next time I will come with another liver infections, bacterial and viral infection. So keep watching my videos and keep giving me feedback. See you in the next video. Bye bye.